Okay, GERD. Absolutely, I'm confident that you've heard of GERD before. It's gastroesophageal reflux disease. Okay? So, what is GERD? Well, it's the backward movement, so that's the reflux, of gastric contents, into the esophagus. Okay, so again, here's our esophageal, gastroesophageal reflux disease. Okay, so it's due to relaxation of or incompetent low esophageal sphincter, pyloric stenosis, increased gastric volume, or motility disorder. Okay, so incompetent esophageal sphincter, pyloric stenosis, increased gastric volume, or motility disorder. Okay, so here's our esophageal sphincter. So if that doesn't work right, some of this can back up into the esophagus, causing the symptoms of GERD. Other things that could happen with it, remember, increased gastric volume or motility disorder. So if our volume's too high, some of this could back up, or if we're not moving forward. Okay, so we're not closing off, we're too full, or we're not moving forward. That could cause the contents of the stomach to move backward. Okay, so what are the symptoms with it? Well, symptoms are heartburn. Okay, and that heartburn is going to be exacerbated by bending over, by straining, or by sitting in the recumbent position. Regurgitation, so the patient may be regurgitating some of the food, some of the gastric contents, hypersalivation, difficulty swallowing, and dyspepsia, which is discomfort in the upper abdomen. So they may have some pain here, feeling of heartburn as that's getting into the esophagus. Okay, the gastric acid is getting into the esophagus and burning there. Which again could be, if they bend over, if they're straining or lying in the recumbent position, that could increase the backward flow of the gastric contents. They may have difficulty swallowing, and they may hypersalivate. Okay, now one thing we need to keep in mind here is anytime we have a patient complaining of heartburn, it can be very difficult to convince that patient, especially if they're an older male, that this may be more than just GERD. Okay, heartburn we want to take seriously because a lot of patients can attribute heartburn, or they can attribute chest pain to heartburn. So we really want to differentiate chest pain versus heartburn. Of course, chest pain could be indication of angina, and possibly the patient is progressing towards MI. And my dad, in fact, it took me months to convince my dad to go to a cardiologist, get an EKG, stress test, and everything, because he was complaining of heartburn, is what he called it, quote unquote heartburn. He finally went. He said it was, it's just got to be heartburn. I told him finally, look, don't be stupid. You have to go to the cardiologist. You need to get this checked out. He did, went and got it checked out, found that he had a 90% occlusion of a major coronary vessel, and it went in for a stent. So he was weeks away, days away, hours away from a heart attack, because he thought his chest pain was simply heartburn. So it's important that we distinguish symptoms. We don't take any one symptom and say, boom, it's this, or boom, it's that. We take these symptoms, we distinguish what they are. You say you have chest pain, you say you have this heartburn. Do you notice it increasing when you bend over, when you're straining? Do you notice any regurgitation? Do you have any difficulty swallowing? Do you have any discomfort in your upper abdomen? Okay, so those are the types of things we want to distinguish to try to draw the line between chest pain and heartburn. So diagnosis is made via pH test. If we can get a pH test of that regurgitation and things like that, we find it to be more acidic. Okay. We'll find it will be more acidic. Well, sorry, that's gastric contents. Don't pay attention to that. So we'll find that it'll be more acidic. And then we can also do an esophagoscopy, which we can send a little camera down into the esophagus and rule out any sort of malignancy. We're going to avoid medications that decrease gastric emptying. Of course, this would be like anticholinergics. Okay, So we don't want to slow down gastric motility anymore. We want to make sure food is moving forward. We want to elevate head of bed. This is going to prevent regurgitation. And we want to give certain different medications. Some medications we can give are antacids. That will help to prevent this burning pain, this chest pain hopefully. And then 2 other medications we can give are H2 receptor antagonists and proton pump.